again, it will be in that same module, because this is the only module I have you all, okay? I have no class with you. Let's start about the upper GI and lower GI. And let's start with some basics. So for any fluoroscopic examination, even if it's an upper GI or it's a lower GI, everything starts like in clinic. When the patient comes, you're asking about preparation, right? So the patient preparation is the common requirement for all GI fluoroscopy examinations. Esophagram, upper GI, small bowel series, lower GI, like bare minimum. Now, the lower we are, the more extensive preparation is needed. Because what is the purpose of the patient preparation? We want to see that part free of everything. Free of food, free of feces, free of everything. For esophagram, look, the food doesn't stay in esophagram. It's only passing through the esophagram, right? So if it's only esophagram, not followed by upper GI, esophagram only, how much it takes for the food to pass through? Like this, right? But still, we're asking patient to be NPO at least 4 hours. Why? Because the mucosa is activated after we eat, and it looks differently on the x-rays. Okay, it's a little more swollen, it's a little more active to calm down the mucosa layer of the esophagram. So we like at least need 4 hours to be NPO for the most upper part. Then when we eat, the food sits in the stomach, right? And it sits longer already, because this is what it takes time to process. So to clean up that stomach out to the food, so the patient preparation needs to be longer. It has to be already 8 hours at least NPO. Plus not smoking, not chewing gum, because everything, all this chewing gum and smoking. So again, body thinks we chewing gum, body thinks, okay, the food is coming. It activates the mucosal layer. So one of the, like another preparation requires not only NPO 8 hours, but also not smoking, not chewing gum. Then we're going to the small bowel series, right? Food travels next to the small bowel series. And the small bowel series, like everything adds up, right? In addition to that, then depending, like in addition to being 8 hours NPO, but we still have to, like, you know, clean this one. That's why, based on the hospital protocol, so the patient has to be on the laxative, on the clear diet for at least 24 hours. So depending on the protocol, but the purpose is not even enough to be only 8 hours NPO for small bowel series. Why? Because it's going to be still leftovers. And the last part of the GI, right, is the large intestines, where the feces sits for longer. This requires most extensive preparation. Is light meals, a clear diet for 48 hours, laxative the night before, the enema the morning of the examination, on top of that 8 hours NPO. We will repeat that as we go. Now, when we are examining esophagus, anatomy for every single part, at least basic anatomy, is like just, we all have to know. So, you know, GI is just one single tube, right? That like changes in its appearance as it goes. And it starts from esophagus. And esophagus in the adult is about 24 cms long, about 10 inches long. And we should know where it starts. And it starts where? C6, which is laryngopharynx, right? It starts from laryngopharynx and extends to the stomach, right? What is the junction between esophagus and the stomach? How we call that part? Cardiac orifice. Don't ask why it's cardiac. It's just because. But this cardiac. Cardiac orifice. This is the junction between esophagus and the stomach. is not straight tube. It has two natural dents. It has two natural indentations. So meaning like when it, inside our body, two structures are touching the esophagus, making those two natural indentations that might be part of the test. One is created by aortic arch because it's just like next to each other. Aortic arch is pressing to the esophagus, creating that indentations. And also the left main bronchus. Left main bronchus also touching the esophagus and makes that natural indentation. So that is the basic anatomy of the esophagus. When we're doing the esophagus and we're discussing those, views, keep in mind that you might be confused, just like we don't do the views, for esophagus. We just do the fluoro. Yes, mainly it's a fluoro, 99% is the fluoro. But guess what? In real life, in radiography, the plate esophograms are possible. And I was talking to my lab students, like explaining, like I had that too, like working in the X-ray department on the weekend when we have just one radiographer, and I was getting the grandma, like I don't know, 80 years old, because she said something stuck in my throat right here, and doctor, attending doctor, physician ordered the esophagram. She is barely like, she cannot stand, she cannot do anything, and radiographer looked like the order and just like plate her. Meaning what? We don't do the fluoro. We're doing plating only. Regular x-rays without fluoroscopy. So this is what those views are about. Okay? So, but before we starting any exam, and it's again, for any GI, because this is the single tube again, that starts here and then, at the anus. For any fluoroscopy GI examination, before we starting, we have to see contraindications, because what do we use? What type of contrast we usually use?
Barium sulfate.
Barium. But we have a two at least, major contraindication for any GI studies, for any esophagram and upper GI small bowel fluid. This is also a big part of the, tests. So, two major contraindications for barium studies. Why? Which ones are they? Risk of perforation and risk of perforation is very good, and risk of obstruction. Obstruction again is not constipation. Don't confuse those two parts. Constipation is constipation when the colon is blocked with the feces. Obstruction, when that tube that we described, right, closed. Something happened, and the lumen, that opening, closed, collapsed. Means what? Whatever that food comes in cannot go through, and builds on top. That's what this obstruction is. We have different types of obstruction. We will review them. But the risk of perforation includes is not like what considering the risk of perforation. When we asking the question, or you can be given the situational questions, like okay, patient came for whatever small bowel series, barium enema, doesn't matter, and he had a recent biopsy. Can you use barium? No. Why? Biopsy taking part of the species, right? Making that a little kind of not whole hole, but thinning the wall, right? So that's the risk of perforation. Recent surgeries, risk of perforation. Perforated ulcers. Ulcer itself, the ulcer, like little spot, inflated spot in the mucosa, is not a contraindication. Perforated ulcer, it is major contraindication to use barium. Why? Because then anything that can make barium escape the GI tract and go into the surrounding cavities, this works as the foreign body for our bodies. So because it's not water soluble, if it escapes, it sits in the cavity. How are you going to take it out? Surgery. This is is why it's a major part of understanding. Anything that can cause barium to escape the GI tract, barium cannot be used. What can be used then? Water soluble. Why? Because if it escapes in the cavity, absorbed by body, eliminates by body naturally. Right, so that's also, always keep in mind, patient preparation, contraindications. This is something that we are asking even before we start. Okay, so here patient came for esophagram, we verified the preparation, we verified for esophagram still can be, you know, like not using barium, very, you know, rare. But if, you know, because the barium goes still there, like any, go into GI tract, not only, you know, passing the esophagus and stays in the esophagus, it's still valid questions like, is there any recent surgeries or biopsies? Why? Because the barium goes into other parts of the GI tract as well. And then, again, every single fluoroscopy exam starts with what? Scout. Right? Every single fluoroscopy exam starts with the first image, where we are evaluating the patient preparation. Every single fluoroscopy, regardless of part, first image, scout. So for esophagram, when we're doing scout, so of course it's usually an AP. Some says it's PA, the textbook says it's PA, but it's just textbook purposes. So, and here we just have to remember the centering points. And the centering points for esophagram across all the views is what? T6. If you think about esophagram, just think T6. Now, how do we find T6? You hear what the chest helps us with, right? Because we know chest is centering point is what?
T7.
T7, okay, let's go inch above. So meaning instead of 4 inches below the jugular notch, we're going what? 3 inches below the jugular notch. If we see if it's a 4PA, instead of centering at the inferior angle of the scapula, we're gonna go what?
1 inch
above the inferior angle of the scapula. That's how we're finding T6, and T6 stays across for all the views for esophagram. What are the views? So we have scout, and then we are doing the actual esophagram plating views, right? Here the scenario is discussed when we're doing plate esophagram. It's still possible, and it's still part of your, you know, book and board. So, for PA or AP, the patient can be laying down, the patient can be standing, you know, depending on the patient condition. So, and the body part placement, we're making sure the patient is not rotated. How we making sure that? Remember, mid-sagittal plane, perpendicular to image receptor. So, now we're giving the patient, you know, the barium to drink or any contrast media of choice to drink. We are centering again for T7, which is 3 inches inferior to jugular notch. Now, when we're doing the actual plate esophagram, how are you instructing the patient when you're exposing? So we have to do the late exposure, meaning we are asking patient to start drinking, right? As he drinks, we have to wait few seconds until the barium fills esophagus, and then we are exposing. Meaning, like in real life, we're doing like I do 1, 2, 3, shoot. This is when they we are instructing them to keep drinking. Okay, that would be AP. Any questions? Then the next routine view for the esophagram, it's RAO. Oh, here it is. RAO. Why it's RAO? First of all, it brings, you know, esophagus closer to image receptor. What is about this oblique view? What is the most confusing part? Is degree of obliqueness. Because no, it's not 45. No, it's not 45, it's a little less. And why is little less? It's 35 to 40 degrees. Because that angulation helps to place esophagus between the heart and spine. If I show you the next image, you will see that. You see how nicely then, with this obliqueness, 35 to 40. Esophagus, you see the indentations, by the way, here? Those what I meant. You see how the dents are?
From the
aortic arch and the left bronchi. So, and the esophagus is nicely between the heart and spine. That's why that will be angling, not 45, less. 35 to 40 to place esophagus between heart and spine. The rest is the same. The leveling, the centering level is T6, but in addition to that, because it's oblique, right? So we are going 2 inches laterally, right? From the elevated, from the spine. 2 inches towards the elevated spine. So that's where the, our esophagus is. In real life, again, I've told my, lab students, so you should follow the neck. If you're not sure where the press here, the center, look, our esophagus starts from our laryngopharynx, mid-neck, okay? Like a little anterior of the neck. Just follow the neck. Just please, place it at the level of the mid-neck, approximately. Again, we are obliquing 35 to 40 degrees from prone. You're making sure still that the top of the image receptor is 2 inches above the shoulder. Always, like similar to chest. So we are giving the patient contrast, usually with the straw. Of course, we're using the 14x17 image receptor placed portraits, centering at T6, and 2 inches laterally from midline to elevated towards the elevated side. And so how we know that we have a good oblique view? The thoracic spine and the heart are not superimposed over the esophagus. So meaning esophagus is nicely placed between spine and heart, and that's why it is not obstructed. It's the least obstructed view then. Any questions?
Just to clarify, Professor, you said plating refers to what exactly?
Plated meaning that you're not using fluoro, you're doing the static x-rays.
Okay, from the regular.
With the plate, with the image receptor. Like, that's just our slang.
Okay.
Like plating, right? I mean, you understand all the meaning of plating, right? Meaning that we are doing x-rays, not the fluoroscopy. We're doing 1 x-ray, 2nd x-ray, 3rd x-ray on the image receptor or a plate. Like, this is, that's why we call it plating.
Thank you.
Yeah. And the third view for the esophagram is lateral. Regular lateral, usually it's a right lateral. It's just because you're facing, like if you're doing the right lateral, usually like you're facing the patient. In this case, it's easier to control. So same centering level. I will upload that, don't worry. Same centering level, T6, but only we have to go 2 inches anterior to thoracic spine. Again, you don't know where the spine, mid-neck is your spine. Spine goes like this. Like, mid-neck, 2 inches inferiorly, that will be your centering for the lateral esophagram. Now, what is the purpose to do the lateral view? Again, for any GI views, and here's put it right, write it down, make a note. What is the lateral view shows? On esophagus, on the upper GI for stomach, on the lower GI for rectum. It shows posterior part. Retrospace, what we call retrospace. It's the space behind the esophagus, space behind the stomach, space behind the rectum. Because on AP, you don't see what is behind. On oblique, you don't see enough, right? But you clearly see, if anything behind on the lateral, So you will see it on the, if it's something on posterior part of the esophagus, you will see that on the lateral view.
Professor,
Yes.
so behind the area of interest, basically, right?
No, the area of interest is behind the anatomy of interest. Like, if it's esophagus, right? Again,
The
you see the
anatomy of interest.
indentations. If something is on the posterior part, I don't know, mass on posterior part of the esophagus, you will do AP, you will not see it, right? You will do oblique, maybe you partially see it, but you will clearly see that. If something on the back of the anatomy, right, you will see that on the lateral view. Retrospace is demonstrated on the lateral view. For any, again, GI studies. That's something common. Any questions? Now, we're going to upper GI. For upper GI, already longer NPO time, 8 hours NPO. Not 24, 8 hours is enough. What is challenging with the upper GI? With the upper GI, the main challenge is the centering point. Why? Because it simply depends on the body habitus. Now, but it's a good practice to just know the major level for the average patient and then go either above or below, depending on the, on the situation. Now, we said, if we're talking about the esophagus, what the level is that we have to all remember?
C6.
T6, right? If we're talking about the upper GI, the level that we have to, as a reference, to go from is L1. L1. But now it's the tricky part. Because many questions ask you that, like, L1, how to find that L1?
Midway between lateral border of the rib and the xiphoid.
It's one way, or you're palpating inferior rib margin and going 1 to 2 inches above, right? So 1 to 2 inches above, that will take you to level of L1. And remember that, because for then this is what we centering when we are talking about the average patient, sthenic patient. And now also, we need to remember that the stomach is on the left side, meaning when we're finding the L1 level, right, we are going at least 1 inch towards the left side, because our stomach is on the left side. But that's for average patient. But then we have 2 more types, right? We have a hyposthenic versus hypersthenic. And this is like, again, the reference is L1, which is 1 to 2 inches above the inferior rib margin. If it's a hyposthenic patient, skinny patient, what happens with the stomach? It becomes lower and vertical. So we're going 2 inches below the level of L1. 2 inches below the level of L1. So we are 2 inches above the inferior rib margin, right? So we basically have to go what? Level of rib margin, right? So that would be 2 inches below the L1. But it's opposite for hypersthenic patient. Why? Because the hypersthenic patient, the stomach is much higher and is transverse, is horizontal mainly. So now we're going 2 inches above the L1 and mainly to the midline. Why? Because it's not like vertical, it's horizontal. Again, you're starting from L1, but you remember how to find that L1. Why? Because they can not mentioning L1. They're gonna, okay, for the asthenic or hyposthenic patient, we are centering 2 inches above the inferior rib margin, true or false? And since you see that 2 inches above, it might trigger you that, yes, it's true because it's 2 inches above, but it's 2 inches above L1. You understand that part? So, like, if it's, the question says 2 inches above the inferior rib margin, it means the level of L1. Then what? The answer is false. Or like, you know, this is what, like, you have to be very careful. And here when you have to slow down, kind of, and, okay, wait a minute. I know, L1 is between xiphoid process or inferior, depending how they're asking, or 2 inches above, like, between xiphoid process or inferior rib margins, or 1 to 2 inches above the inferior rib margins, and this is like, okay, that's L1. And again, go back to question, what it asks you, which type, because then it have to be either 2 inches above that point or 2 inches below that point. Make sense? Okay. This is the PA or AP. Now, for the upper GI, that's the study. When they are imaging patient, like making him rotate 360. Why? It's not working like in other views, right? RAO shows the same structure as LPO. Or LAO shows the same structure as the RAO, right? No, it's not working with the stomach. The stomach, you have to do LPO and RAO, or RPO and LAO. Why? Because in all these views, different part of the stomach will be shown. Different part of the stomach will be filled with barium. Because when you're doing LPO, right? LPO, and this is my stomach. This is my stomach. Stomach is like this. Water bottle. Stomach is like this. This is fundus, which is the highest as more posterior part. Highest as more posterior. And this is the pylorus. Pylorus almost like very close to anterior part and is the lowest one. Okay? Higher and posterior, in like superior posterior is fundus, or highest and more posterior. Why it's important to understand, guys? Because then you don't have to memorize which view stomach will be, which part of the stomach will be filled with barium. You simply thinking about the gravity, and gravity only. This is my stomach. If I'm standing, which part will fill with water? Pylorus. What has air? Fundus. If I be supine, which part will be filled with barium?
Fundus.
Which with air?
Pylorus.
If I'm be LPO, which part would be with the barium?
Fundus.
And with air?
Pylorus.
That's all. Gravity. If I be supine, I mean, of course, prone. Which part will be with barium?
Pylorus.
And the air?
Fundus.
Okay, now I'm in what? RAO. In RAO, fundus will be what?
Air will. Air
Air.
filled.
What will be with barium? Make sense?
Yes.
That's it. You're never gonna remember for any views. What you have to do, just think about the bottle of water. Place it as a stomach. Okay, and remember, fundus is closer to the posterior part, and pylorus is anterior, and fundus is higher. If whatever be standing, by gravity, the barium goes to the lower part. If we're laying down, by gravity, the barium will go to the lowest part, closer, the part that's closer to table. And that's, just imagine that water bottle, and just play in your imagination, which part will be filled with water, if I be placing it like this way or that way. And that gravity rule is same and true for anything. Upper GI, lower, like the barium anymore, because it will be also like which part of the colon is filled with the barium and air. Just you have to think about the gravity. On which part of the BE decubitus, part filled with barium versus air. We will go later that we will show the diagram how to find the areas that filled with barium and air. But again, gravity rule is true for every part of the GI. Simple?
Yes.
Yes.
Very simple.
Now, the patient is in a PA. Which part of the stomach will be filled with barium? Pylorus. Why? Because look, again, here's like this, right? And I'm prone, right? What is like close? Pylorus. What is filled with water here? Pylorus. Makes sense? The air is where? Fundus. Now, REO. Again, how to here obliqueness are, because as I said, we're doing an REO and LPO, both. And here is also tricky part might be on your test. Oh, if it's REO, it's the same as LPO. Nope, nope. Why is nope? Because different opposite parts will be shown. For those same angle, right? But in one angle, fundus will be filled with, barium. In another angle, pylorus will be filled with barium. That's why for GI is 360. And even if you get a fluoroscopy, have you noticed if you did the upper GIs, how radiologist asks patient to do the complete rotation? That's exactly why. That's exactly why. So, what is again challenging with this one? Because it's not regular obliqueness. So for this, same rule applies for the average patient. And this is you just have to, I would suggest you to memorize the centering level and the body rotation for the average. And then see the options, because you will know which way to go from that average. You know that for the skinny patients, we are obliquing less because it's a vertical. It's easier, to see. But for the hyper is the horizontal. You have to oblique more to see the sides of the stomach. I'm dancing here, like a workout. So, stenic. Same thing. L1, 1 to 2 inches above the inferior rib margins, right? And just here is basically the close to regular 45-degree oblique. But what happens with the skinny asthenic patient? You do obliquing less, and for the hypersthenic, you're obliquing more. From 40 to 70. 40 to 70. 45, 55 is the middle one, but you're going less for the hypo or asthenic patient, more for hypersthenic patient. Now we're going to REO. Here, oh yes, REO that was. Okay, tell me in REO, which part of the stomach will be filled with barium? Pylorus, right? Is like this. Here's my fundus. In REO, pyloric is closer to the table. My God, my back. Okay. Lateral. For the lateral, same rule with the centering applies. You still remember that for average, we're going only 1. For the asthenic, we're going 2 inches above. Hypersthenic, we're going to inches below. However, if your area of interest, area behind the stomach, that's the view that will demonstrate that. Retrospace, okay? Retrospace, posterior wall of the stomach. Any mass, because you can be situational question. Oh, physician is concerned with the whatever mass on the posterior wall of the stomach, which view will just demonstrate that. Okay? Lateral. Keyword is a posterior. Yeah, retrogastric space. You see here it says retrogastric space. Now, LPO is opposite to REO, still needs to be shown. Here is like from 30 to 60, you know, like there, you remember the opposite was RPO, it was 40 to 70, here is 30 to 60, with a 45-degree for the average patient, less for the hypostenic or asthenic, more for hyperstenic. In LPO though, which part of the stomach will be filled with barium? Look at this image.
The fundus?
The fundus, very good, because fundus will be closer to the table. Fundus by gravity will be lower than pylorus. Like other way to think, okay, what is the higher part? Pylorus is higher or fundus is higher? Pylorus is higher, then air is up, fluid is down. Okay, so AP, again, is not the same as PA. It's same centering wise, but it's different with the, what part of the, you know, for AP, which part of the barium? Barium. Which part of the stomach will be filled with barium? Fundus. Okay? So here is the example of the position of the stomach. So, of the hyperstenic, stenic, and asthenic. I was telling the story, you know, like I never forget, we were doing the x-ray for NG tube placement on a very tiny, teeny, skinny lady, grandma, is obviously grandma. You know, and we were looking for the chip of the GI tube, you know, NG tube, you're looking for the chip to make sure it's in the stomach. And on x-ray it was here. We were like, did we penetrate the, you know, like it was so weird, like, okay, we send it to the radiologist, like I call, like, can you take a look at this, like, NG tube, you know, placement? And like, I was waiting for report, like, what the radiologist is gonna say. And the radiologist says, tip of the NG tube noted in the left lower quadrant. Perfect. You know, whereas, like, is it in the stomach or not? So we had to do the, you know, the gastrographic injection through the NG tube to see if it outlines the stomach. And yes, that's how low that stomach was on her. It was in the stomach, you know, I never forget that story, you know, crazy. But that's true, like how the stomach changes, you know, with the body habitus. Okay, was it helpful?
Yes.
Okay.